anesthesia considerations for laser surgery. Let me introduce you. Laser, you know everything about light amplification by simulated emission of radiation. What does laser do? Provides a source of focused, coherent light capable of transmitting intense energy to precise location. And what we desire is destruction and cauterizing of tissue. What is the difference between normal light and laser light? It is monochromatic. It is coherent. Coherent is it forms a hole, kind of a very focused hole, and collimated, meaning it is a parallel beam. So why to go for laser surgery? Because it gives you clear and dry field while operating. It causes less post-operative pain. There is no direct contact with mechanical instruments like cutlery and all. Wavelength is very specific. So microsurgery of different kind of tissues is very, very possible. It's high temperature phenomenon, so almost bactericidal. There is precise cutting tool because it is a focus beam and it can be assisted by computer. So that is why laser is becoming more and more popular. But of course, there are demerits of using laser because it's a very high temperature field. So it can ignite flammable materials in the field while operating. And airway fire, which we are going to talk in detail later, is the most dreaded phenomenon which can be faced by anesthesiologists and the team. There is risk of eye injury both for the patient and the staff, especially surgeon. There is difficulty in access to the surgical area as well. Sometimes there could be airway loss, having the catastrophe in operating team, and of course the high cost. Have laser surgery in clinical practice almost everywhere. In ophthalmology, orthopedics, urology, dentistry, GI surgery. But for us, being anesthetists, ENT surgery tops the list. And we will be focusing more about ENT surgeries because that's how we are sharing our airway with surgery. And of course, not to forget about dermatology, where beautification is done by most lasers. Coming to preoperative evaluation of patients who posted for surgery. Of course, like usually, we have to go for coexisting diseases. And mostly, when we are talking about laryngeal or tracheal problems, we have to see for the location, size, extent, and mobility of the lesion, whether it is labile, whether it is hard, because that will decide about the type of lesion and how to go about managing the airway. There could, if it's a very big tumor, it can have difficulty in breathing. There could be difficulty in swallowing. Patient could be having snoring, stridor, wheezing. That will definitely be affecting your anesthesia protocol. And there is one more phenomenon which we generally do not do as anesthesiologists is grading of laryngeal obstruction. That is mainly done by surgeons, but I'm quite suspicious whether it is done in our setup also, because just to tell you the fact how this laryngeal grading is done, it is like a CLE test, what we call it as. It is from the scale from 0 to 3, CLE test, where assessment is usually done at both glottic and supraglottic levels using a continuous laryngoscopy, that is CLE test. Just imagine patient is on the treadmill and there is a very thin kind of laryngoscope which is inserted through nasal cavity and patient is having his exercises and the surgeon or the technical person is monitoring how patient is getting obstruction. So it sounds very, very kind of scary. So I don't think any surgeon in India is going for CLE, but just to complete the list, I thought of sharing with you that how grading of laryngeal obstruction can be done. 0 says there is complete patency, no obstruction, we are happy. And 3 says almost complete closure of glottis while patient is doing exercise. So this, in a way, can diagnose exercise-induced laryngeal obstruction. And score up 2 or high, definitely patient is having abnormal or significant obstruction. This is just to complete the academic forum. Coming to investigation, like routine, we have preoperative investigation like any other case, especially spirometry and flow volume curve, because this patient can have obstruction, extrathoracic obstruction. So that also must be documented. If patient's spirometry can be abnormal, you have to go for ABGs also. X-ray, CT scan of larynx, everything have to be done to assess extent of airway. But the surgery timing is very low or small. The kind of catastrophe patient can face can be very lethal. So you have to be very, very careful while selecting the patient and optimizing. Coming to optimization and planning of the surgery. You have to always discuss your plan with the surgeon if airway obstruction is present, because that's the most vital thing. Surgeon is quite aware what anesthesia is facing because it's a common kind of airway disaster. Anybody faces it. You might have to give bronchodilators for this patient. If there is a extraneous obstruction also, antibiotics prior to surgery may be given, though not very common for this kind of surgery because it's almost bactericidal. If patient is having lot of secretions, you might have to give glycopyrrolate routinely. In now modern clinical practice, glycopyrrolate is absolutely not very much indicated in everyday practice. You must have to avoid sedatives because there could be airway obstruction and just giving premedication sedative can lose your airway. What are the options available? You can have TIVA or transtracheal joint ventilation, but we are going to discuss in details. and mode of anesthesia. Like usually this is the kind of thing which we are more interested into while we talk about laser surgery. We can have general anesthesia with controlled or spontaneous ventilation with ETT, or we can have without tubeless fill with intermittent apneic ventilation. How do you prepare our OT? Of course, difficult airway cart is must for all airway surgeries. We have to have devices to protect our ETT, or laser tube and tracheostomy tube. Our windows of OT should be opaque because the beam can be very disastrous for the bystanders also. There should be warning sign on our door. There are very kind of designated OTs in OT complex. We should always have our scrub nurse ready with 20 to 50 ml saline in the trolley, because in case sudden airway fire, you can extinguish that. This is a very small thing, but it goes a long way in having a safety in the operation here. Coming to induction like usual, choice of agent depends upon comorbidity, but it's a caution. We have to use everything else but the ketamine, because the ketamine has an advantage of having airway reflexes intact, which is not desirable, especially in laser surgeries. If there is no obstruction, we can have our standard induction. If the airway is compromised, of course, awake fiber optic can be a better choice. If patient is uncooperative, we can have inhalation technique with sevoflurane and spontaneous ventilation. Airway management, a very important kind of aspect as far as laser surgery for ENT. Surgical site is more important, whether it's glottic, supraglottic, or infraglottic. What is the degree of airway obstruction that has to be documented? Which type of laser is used, whether it's CO2 or NDR or extimer. But normally, what I have conclusion, it's a CO2 laser which is commonly used, and sometimes, especially in plastic surgery, they have IPL, that is intermittent pulse laser, which is a very common kind of technique used in plastic surgery. And of course, coexisting medical problems should be taken into account while you manage your airway. Sometimes you might have to do tracheostomy under local anesthesia because the tumor can be so extensive that any other anesthesia will be totally contraindication, and you have to go for laser surgery. In that case, I think we are quite safe because tracheostomy is already done and surgery is happening at the higher level. The most important factor what laser surgery poses in front of us is airway fire, and there are threefold kind of difficulties what we can have. What three things which are required for airway fire is first is energy source, and all types of lasers or electrocautery can act as an energy source for this airway fire. Second is fuel source. So red rubber tube, silicone tube, all unprotected cuffs, non-metal object can be a fuel source for this airway fire. And we talk about oxygen and nitrous oxide. They don't combust on their own, but they help in having the combustion. So they act as an oxidizing agent. So energy source, oxidizer agent, and fuel source are three things which combine to have an airway fire. Though it is very uncommon, if it occurs, it can be a disaster situation and it could be very, very lethal. But this airway fire, we have to have our ET tube protection against laser. So we have red rubber or PVC tube. Generally, what we used to have before, having this metallic tapes. But nowadays, I think this metallic tapes and everything is obsolete because we have lots of good laser protective tubes, which we are using right now in Sassoon Hospital also, and in private hospital where they are having everyday laser surgeries like Dinanath Mangeshkar Hospital. I'm going to talk about their workload in a couple of minutes. So these metallic tapes, we can be used using adhesive benzoin tape and without any wrinkle. And there should be 30 to 50% overlap one over the other. And we have to include the inflation tube also to have a maximum protection. This kind of scenario can be seen while we are just holding the metallic tube over the laser tube. It can be of three types, aluminum or copper or plastic tube. This is just for academic purpose. Nowadays, nobody is using this metallic tube in the clinical scenario. So what problems this metallic can have? There is no cup protection. The tube very thickened. It is not at all FDA approved device. It is like a jugaad what we use in otherwise anesthesia protocols. And protection is variable depending upon what kind of metal foil you are using. This adhesive backing also can ignite. If the temperature is too high, it is a reflective surface. So laser can reflect onto non-targeted tissue and unexpected tissue damage can occur. Mucosal surface also can be damaged because the tip of this rough edges can have a continuous kind of abrasion, and later on you can have mucosal edema also. The tape can loosen, break off, and can be aspirated. And then that can be like a foreign body bronchus kind of a situation. And this tube can make excessively done. It can cause a extraneous tubal compression. So there are some special laser ETTs available to combat all this complication what the metal tape can pose to you. So special laser tubes, there are three types. One is laser resistant, which could be Zomed laser shield tube or laser shield type 2. Metal tubes like Norton tube, Bivona foam cup tube, and laser flex tube, and rubber tube like Sheridan laser tube. All these are available in the market. But to shortlist, laser flex tube is the most commonly tube used in India, and it's quite affordable. I think one laser tube costs something about 5,000 to 8,000 depending upon the size. and that can be reused also. I'm going to talk about it in a couple of minutes. So coming to this Zomade laser shield tube, it is integral laser resistant coating. Itself is a laser resistance. It's made of silicon with outer layer of fine powder of silicon, and the specifically used for CO2 lasers. FiO2 of less than 25% should be used, because more the oxygen, more the chances of combustion, because it's a oxidizing agent. It's more resistance to laser than PVC or red rubber or routine. But disadvantage is it forms silica dust on ignition. When there is a beam is passing near the tube, the silica dust is formed, and that forms a silica plume, and which can be hazardous to patient. Coming to laser shield 2, as it suggests, there are two folds. The silicon-based ETT, which is wrapped in two folds. First is aluminum foil, and then it is wrapped in polyurethane tape to smoothen the tube. And the cuff is made of unshielded silicon elastomer designed to expand with saline, and it includes methylene blue diatin. Why this methylene blue? Because whenever accidentally the cuff breaks, the methylene blue color will be evident to the operating surgeon, and that can indicate that there is a perforation, and then you can take the necessary precaution. The distal cuff and 1 centimeter proximal is unprotected. So that you have to keep it in mind. There are two sizes, 4 and 5, and it is approved for CO2 and KTP laser. And there are no adhesives which are required because it's already impregnated itself. This is a Norton tube. It's kind of interlocking stainless steel spiral coil. It's a metallic tube. There is no cuff. So definitely doesn't protect against aspiration. And the cuff surface and tube surface is matte finish. So matte finish will avoid having reflection of laser beam. So it will minimize the diffusion and the subsequent tissue destruction, which is not intended other than the papilloma or the tumor, will be minimized. It is a metal tube, so it is reusable, flexible, non-inflammable. It has thick wall, so kind of gives you protection against kinking also. It is used with all kind of laser. It requires jet ventilation. And of course, being non-cuff tube, it is prone for leak. It is rough, so can cause tissue damage. It's a metal, so it can twist with secretions sticking it to it, and ventilation could be difficult. These are different tubes which are available in the market and used according to the availability. It's a Bivona foam cup. As the name suggests, it has self-inflating polyurethane foam sponge, the silicone envelope cup. The cup is initially filled with saline during use, and once you insert it, it will keep on self-inflating. And whenever there is puncture, accidental puncture, it prevents deflation. So IPPV may not be hampered, but the complication that what can happen because of this, suddenly you have to extubate this tube. The tube extubation will be difficult because the cup doesn't deflate. One more advantage is tube remains intact even if silica is burned. So there is no problem about patient having obstruction. This is Sheridan laser tube. It's a red rubber tube with copper foil tip. It is pre-copper foil tubbing in the market, and it's a single cup. Sizes are 4, 5, and 6. Now this is laser tubes. It's a cup within the cup. We have two cups, as you can see it here, cup within the cup. And the inner cup seals even if outer cup perforates. The inner is filled with air and the outer is with liquid. So outer, whenever fills up, it will definitely extinguish the fire also. So it serves a two purpose. There are sizes like 4, 5, 6, 7, and 8 millimeters available. This is the most commonly used tube. We also have it in our hospital, and the institute which does a lot of surgeries of laser in ENT surface are laser flex tube. Like Dinanath Mangeshkar Hospital, I want to special mention to them because at least every day, on an average, 2 cases they are doing. So their team is quite thorough with how to go with laser problems, and touch wood now, up till now, they didn't face any single complication like airway fire. The rest, I think all of us are able to manage. These laser flex tubes are airtight stainless steel spiral with smooth surface and matte finish. And there is Murphy eye also. In case there is a kind of obstruction, the Murphy eye can come to your rescue. There are 2 distal PVC cups. I am going to show the figure also. The distal cup remains intact in case of puncture of proximal cup, and the proximal is filled with saline and the distal with methylene blue. So suppose the distal cup perforates. That means now the tube is totally kind of disastrous because methylene blue is out. So already that means proximal has been perforated and you have punctured the methylene blue also. The wall is thicker than other tube, and there are sizes available from 3 to 6 also. Uncuffed from 3 to 4 and cuffed from 4.5 to 6. This is the most commonly used in clinical practice. This is how it looks. These are the 2 tubes, proximal filled with methylene blue and saline, and the distal one, and the proximal with normal saline. But the demerit is its stiffness and roughness. There is large external diameter, so it's not suitable for pediatric cases and the small patients. And the small internal diameter restricts the flow of air, adds the time of extubation and intubation because a double tube, double cup. So whenever you want to extubate this in case of emergency, you have to go for first this and the second is this. So in case you forget to deflate the second cup, in case of hurry, the problem could be increased. Coming to ventilation strategies, I think this is the most awaited part of laser surgery. How do you ventilate this patient? Having tube is okay, having induction is okay, like normal patients, but how to ventilate this patient? So what are the requirements what we have for laser surgery we want? The surgeon should expect from us that it's a tubeless field. Our tube should not come into his way. And what we expect that patient should be having normal oxygenation and normal ventilation. So oxygen and CO2 should be in a normal level, but that's always not possible while we are dealing with laser and airway. So coming to spontaneous ventilation, we can have it as inhalation and induction and topical anesthesia. Maintenance can be done by nasopharyngeal airway connected to the circuit, and patient remains anesthetized and oxygenated, and you can monitor ECG spontaneously ventilated and precordial stethoscope also, and movements of the abdominal can be monitored, and there is uninterrupted view of larynx. So spontaneous ventilation is the thing which we used to use while patients were in the kind of scenario where we have to share airway with surgeon. So limitations of spontaneous ventilation is what? Lack of complete control of the airway. Nothing you can do when something happens and surgeon is doing things. And there could be apnea or hypoventilation. Sometimes what happens, patient can be a very deep plane and then you can have cardiac arrhythmias. Patient can be in very light planes and can have laryngospasm, and the entire kind of problem is manifold. It's 1,000 times patient can have problems because there is no tube inside and you are struggling with airway also. Here vocal cords are also mobile and surgery can be difficult. You are also struggling and the surgeon is also struggling, and scavenging can be also difficult. And in this case, capnograph also cannot be used. So next is about jet ventilator. Standard jet ventilator, I think all of you which are little kind of older generation like me must have seen the jet ventilation, which is standard jet ventilation. We used to use commonly for not laser, but used for foreign body bronchus. So jet ventilator, I think for oldies, they are quite aware of that. So it is given intermittently using this toggle switch for 1 to 2 seconds inspirated time with the driving pressure of 15 psi. It is directly attached to the pulse machine and giving expired time 2 to 4 seconds only. And you have to observe chest movements, whether it's inflating, and that definitely can have volume trauma because a lot of pressure is going into giving a jet. But you can have adequate ventilation. You can see the chest rise, excellent surgical access to the larynx, and there is no ignitable material in the surgical field and motionless also. So that's kind of an advantage in jet ventilation. But it has potential risk because it's source of oxygen on a very high pressure. So it can literally go into pneumothorax, pneumomediastinum if it's not done properly. Patient can have stomach and feeling and regurgitation also. Aspiration can be also a very disastrous thing, especially when surgeon is kind of resecting, and at the same time, if the jet goes, it can be aspirated in the ventilation also. Because of high flow, patient can have drying of mucosal surface, and later patient can have post-operatively problem with sore throat also. And you have to literally depend upon intravenous anesthetic agents, like you can just maintain the patient on propofol and relaxant. And in this case, lungs should be very compliant for ventilation. So this I'm going to talk about apneic high flow oxygenation. The entire thing, what is concentrated upon is this apneic high flow oxygenation. This is the thing which the people who are maximally operating on laser surgery in ENT field in the Dinanath Mangeshkar Hospital are using it. You will be surprised why I'm mentioning about them, because in Pune at least, they are the ones who are the dons in airway anesthesia for laser. So they have also published case also. I think you can just tell you how the assembly is. This is a very simple kind of thing. This is nasopharyngeal airway. You have to pass it, this nasal pharyngeal airway, and simply you have to attach it to the breathing circuit. You can see it here. See, this nasal airway has been passed into the nasal cavity, and this breathing circuit is attached, and surgeon is being given the case, and you can see the entire surgery being operated here. So this is in-house. They have taken the photo. So what does this apneic high flow oxygen means? We all know that high flow oxygen we have used in COVID very frequently and very extensively. So in actually high flow oxygenation, the limit could be as high up to 75 liters per minute. And you know how much kind of droplet infection this high flow oxygenation can have if it's used for such high liter of oxygen. So that was the kind of game changer for them. So how can we decrease this high flow oxygenation? Can be little less. So they have done a lot of cases according to that, because then they devised this apneic high flow oxygenation. It's very simple and user-friendly assembly. Here spontaneously breathing attempts are avoided while maintaining gas flow as low as 12 liters per minute. Sometimes you can use up to 20 liters per minute also. So the kind of you use the protocol similar to what we are using in otherwise normal airway surgery for optimization. Anesthesia is given with target control infusions. If you have a PCI pumps, or you can use propofol and atracurum as a drip continuously. And the risk of aspiration is very much minimized by judicious use of suction under direct vision by the surgeon also. I think just imagine the patient is given to surgeon, the TCI pump is running with propofol and atracurium, patient is totally apneic. You are giving the fresh gas flow of more than 12 liters up to 20 liters per minute. And the real crux is apnea up to 30 to 40 minutes can be tolerated. You know how the apneic mass oxygenation works, especially in case of difficulty airway. We are using this apneic mass oxygenation, especially obese patient also. But here I have spoken with every one of them. Hey, are you not scared of giving apnea for 30 to 40 minutes with Kiva? They said, no, madam. You have to see it to believe it. So I'm definitely have seen that, and I know how beautiful the technique is. But of course, you know how the risk of apnea for more than 30 minutes lead into. It is too much of hypercarbia. So that has to be taken into account. Post HFO, we have to give second generation laryngeal mask airway insertion. It is always inserted after the surgery is over and patient is ventilated and CO2 washout is done and lung recruitment is done, because at that time patient is not ventilating at all. And then patient is reversed like a normal, otherwise patient is reversed. Many times patient can have a problem during this apneic high flow oxygenation, then tube in, tube out technique is possible. Instantly the surgeon can pass ETT because he has a suspension laryngoscope available already in place, and he will put the tube in and ventilate patient for some time. They take the tube out, and again they can continue with this apneic high flow oxygenation and it can continue. Sometimes even more than 3 to 4 times this tube in, tube out technique can be incorporated while you are incorporating this high flow technique in apnea. So this was the crux why I was talking about laryngeal surgeries and laser surgeries in apnea. So I want my discussion to happen on this scenario only because it is time tested, because last so many years they are doing this apneic high flow oxygen technique without any problem, and it has been published in Indian Journal of Anesthesia in 23. I will share the link to you also on the group, so you can just read about the total scenario what they are facing, and you will be all surprised and become more confident while dealing with such patients in future. So in case of airway fire, though it's very rare, you should be always, as a true anesthesiologist, we are always prepared for the worst. Though it doesn't occur maybe in your lifetime also, we have to know what the airway fire protocol is. There are 4 E's. Elimination. Quickly remove the source of fire and stop ventilating. Otherwise, a scenario like this can be a disaster. Traction. Disconnect breathing circuit. So oxygen source is totally taken away. See, here we have to do some kind of unlearning. Whenever there is any disaster in operation theatre when anesthesia is concerned, the first kind of reaction is give 100% oxygen. In this case, I think it's the other way around. We have to take a paradigm shift and you have to disconnect the oxygen. So while doing surgeries of laser kind of origin, we have to remember this. Disconnect 100% oxygen whenever you are in extinguish. Flush the ETT with water and saline using 50 ml of syringe and then extubate the patient. And then you can put the tube for extinguisher and then ventilate with 100% oxygen when the source is taken away. And then again, we have to evaluate how much damage this fire has taken place in the operation theatre. And in the patient scenario, we have to do laryngoscopy and do rigid bronchoscopy. Maybe the surgeon will do, or you can have an expert kind of person, but no other surgeon than ENT surgeon is capable of doing a perfect laryngoscopy and bronchoscopy, and he can come to our rescue also. If it's a scenario of other faculties like plastic surgery, I think you should have an ENT surgeon in place to help you out in kind of scenario which need to require this evaluating strategy. And if there is any airway damage, definitely you have to go for a definitive reintubation and maybe tracheostomy later, and patient might have to go for ICU setup for elective ventilation. That's kind of the scenario you can face in your lifetime. So what other safety measures you can have for laser surgery besides having airway? You have to protect your eyes with of specific wavelength, which are laser protected. Patient eyes should be covered with saline gauze. The flame-resistant surgical drapes should be used, especially because the surgical drapes also can catch fire. Laser plume. Whenever a surgeon is igniting something, the fume, whatever fume it happens, is a debris. So the debris can be inhaled by you also. So you should have good quality mask like three-ply and smoke evacuators in the operation theatre. And you have to use all surgical instruments, especially matte finish, to avoid reflection and going haywire, otherwise on a normal anatomy. Mucous membrane should be quite covered with saline soaked sock to avoid drying and having a prone scenario for ignition. And fire extinguisher in the operation theatre is a must. I think all other modern anesthesia OTs have this fire extinguisher inbuilt. To summarize, whenever we are talking about laser surgeries, first is airway, then assessment, preparation, and induction, which is very, very patient specific. Airway could be difficult, it could be obstructed, it could be easy. you have to decide about your strategy of ventilation, and you have to know your laser, what kind of hazards you are going to place, and how do you prevent that. And always remember, there could be airway fire, and we have to have the strategy and protocol in your mind and in your OT to extinguish that. Thank you very much.